evening, and welcome to all of you. Thank you for your interest in tonight's program, A Night at the Theater, also known as the Operating Room. My name is Keith Rose, and I am your moderator for this event. We're so pleased that we've got a nice audience here at the Midland Cultural Center. Of course you're nice, but we'd be even nicer if you clap for our speakers and our sponsors. We have a big audience at home watching us on TV, and we have another group of people that likes to stream us. You don't need any access, or you don't have to pay any money to get the YouTube programs live. You can just get them on the YouTube by Googling it. And so there's a large group of people watching us live on YouTube as well. This is the 47th event of our 7-year series. Just for fun, I want to ask, how many of you in the audience remember our first program in September 2016? Now, for those of you who are not fast enough to find your electronic device in your pocket and to look up the list of programs that we had, because it's on the Our Health website, I'll give you a hint. The name of the program was The Good, the Bad, and the Ugly Behind the Doors of the Emergency Department. So I was here. Anybody else? Larry, you were here. Kate? Not very many. Okay. Well, things change over 7 years, but it's great that we've got new faces here tonight. So.
OR isn't as ugly either.
Okay. I'd like to introduce our 4 speakers tonight, and I'll start with the guy immediately on my left, Mike Thor. Mike is a community businessman, frontline, likes to talk about money, but that's not why he's here tonight. Mike has had first-hand experience under the operating room lights several times, right, Mike?
Yep.
Good. Well, thanks for sharing your ideas with us. Karen Redpath. Karen is a nurse with both frontline clinical and administrative experience. She is the Director of Clinical Services at Georgian Bay General. Thanks for joining us, Karen. Ian Wagg is a GP anesthesiologist who's worked at Georgian Bay General and Waypoint for almost 10 years. Now, I do have to, I want to thank you, Ian, for letting me tour the operating room. Ian gave me a personal tour, showed me all the corners of the room, what went on where, and so I appreciate that. But I don't know how many of you know, but I am a retired anesthesiologist. I started actually giving anesthesia here in Midland in the 70s, but I haven't given an anesthetic in a long time. About 15 years ago, I stopped working in the operating room. So, Ian, this is a refresher course for me, so I will be listening carefully, okay? Paige Churchill is a general surgeon, and she's been the chief at the Georgian Bay General for at least the last 4 years. Although I understand when they hired you, you had such great leadership experience. That was one of the reasons why, Paige. She's recognized for her keen interest in quality, not only in the OR, but throughout the hospital. So thanks for joining us, Paige. There's more detailed biographies on all our speakers. It's sitting in your brochure and your program. Again, it's on the Our Health website for each of this program and all the previous programs, so you can look back at it. Okay. Some thank yous before we start, specifically to the advisory committee, many of who are here tonight, but very importantly, Larry Arnold, the guy that got this started. I think the topic was even yours, right, Larry? Yeah, okay, and the speakers and all the other things that we do to get these programs ready, so thank you. Our 7 local sponsors, who I'll acknowledge a little later on, and the extraordinary staff here at the Midland Cultural Center. That would be Michelle, Ashley now, Glenn, who's up in the booth looking after the AV, all the volunteers who work in the box office, who set up the room, who are here tonight, showing us where to sit. So thank you very much for being here. I'd be remiss if I didn't say something about Rogers TV. Josh is sitting up in the booth there from Rogers TV because the cameras are now in the walls, and he just has a little thing up there and makes them move according to how he wants them to move, and we can't see. Anyway, Josh, thanks for being here. And a special recognition also to Georgian Bay General providing the OR video that we included in some of our promotional material. So thanks to all of those people for helping us with the show. During the 90 minutes we have together tonight, I'll engage in a short conversation with each of the speakers about life in the operating room. During the latter part of the event, I'll ask the speakers some questions that interested viewers and our advisory committee has sent to me in advance. So it'll be back to our kind of classical format of 4 speakers talking and then more questions. But we intend to be interactive even when individual speakers are talking. The OR is fast-paced and complex. Every move is critical. The staff work as a cohesive team, and they love what they do. Whether it's attending to a patient having a small procedure as a day patient, or whether it's an emergency requiring complex surgery in the middle of the night. That's the team. Our objective tonight is for you to get to know the OR environment and some of the people that work there in advance of any future unexpected visit that you may need to make to the OR. Okay. Mike, do you want to take it off and tell us about being a patient and what it was like?
Sure. Thanks, Keith.
The highs, the lows, the goods?
Goods, the bads, the uglies. Here we go. I'll keep my shirt on. Because, yeah, I had an unexpected journey to the hospital. I had a mountain biking accident many, many years ago where I, not impaled, but pretty much drove my handlebars right into my abdomen and didn't really think much of it. Was a tough guy, walked away. A couple of years later, I was having some pain. We thought it was diverticulitis, so I was in the hospital for a couple of days, just getting some anesthetic just to get the infection down. And then just kept going on life, just watching what I'm eating, and away you go. And then another incident happened around 2018. And I looked at my wife, Sarah, and I said, I don't feel good. And I woke up in the morning, I said, I really don't feel good. I gotta go to the hospital. There's something wrong. So sure enough, she panicked, so we're off, boom, off to our local hospital here at GBGH. Get ready to emerge, they bring me right in, and I was on a scale 1 to 10, I was probably an 8 at this point. And I was really bad going downhill. And we just thought it was a diverticulitis attack again. Meanwhile, got into the emerge. Doctors did a fabulous job assessing me. Had a quick CAT scan at the time, did some other blood work. My white blood cell count was going through the roof, fever was going through the roof. At that time, Dr. Sachs was the head surgeon, called me in, or came in, assessed me, and it turned out my bowel had perforated. And so I was going downhill fast. They were packing me in ice and whatnot, and she came up with a couple of options and basically said, we gotta do surgery. And Sarah looked at her, what would you do if it was your husband? He says, well, we got about an hour. So I've already called the team. So I didn't have much time to prepare. And I was feeling, I was still going downhill. So that's when I met Dr. Wag, actually, because he was my anesthesiologist doing the procedure. So it was pretty quick for me and pretty scary because I'd really never gone through a major surgery. I had minor hernia surgeries or wisdom teeth out, but that's about it. So I wasn't really knowing what to expect. So I was on the table, I think, for a total of 8 hours. I was in, excuse me, I was in bad shape. They cut me wide open. I just showed these guys a picture, so I've been cut here to here. It took a while, I was pretty infected. They took out 2.5 feet of my bowel, stitched me back together. I came out with an ostomy on, which I had no idea this was on me. And I was in tough shape. I had the ostomy on for about 6 months, went back in and had that removed, surgery again. So it was a long little road to recovery. I was feeling okay, but, just couldn't walk as much as some of my neighbors are in here, they know I'm a walker. I could barely walk down the path. But got up, kept walking around, and I had a really good experience at the hospital, actually. I was in the hospital for a week after the surgery. I had excellent care. Nothing's perfect. There's some funny stories that I share once in a while about some little mishaps that happened, but let me tell you, the care I got out of this hospital was just, our local hospital here was just fantastic.
Do you want to talk about pain control? Because
Oh yeah?
this is a funny story to tell it.
Yeah, actually,
At the time, it wasn't funny, right?
I think it was day 2, and I'm still on Tylenol, and they give me my bolus, and I'm clicking away, and they're going, "How are you feeling?" I'm going, "No, I'm not good. Not good. Get up, walk around, okay." So they tell me to do something. I'm going down to the gaff. Took me probably 20 minutes and come back. And I was in pain a lot today. He said, "Well, geez, you've clicked your bolus a lot today." I said, "I don't know, I'm not feeling good. I'm not feeling good." I go to get the other end, it wasn't connected. So, and the nurse, I felt so bad for the nurse. She was just in tears. And all of a sudden everybody's fussing around doing stuff. "Well, we've given you this 70 liters. And I'm like, "Well, it's not connected, so I'm ow." And I still got stitches in and everything else like that. So she was in tears, and I just looked at her and said, "It's okay, I'm okay, I'm fine. Yeah, I'm a little pain, but it's okay. Things happen, right?"
You were probably just being a tough guy.
Yeah, still, yeah. Trying not to show my quivering lip.
How much pain?
I mean,
2 out of 10, 3 out of 10, Mike?
Yeah, exactly. So it's, little mishaps happen, and away you go, and these things happen, right? And I can tell you another I know we're on public TV, but I can tell that anyway. But we had and some of the student nurses were coming in, and they had to put a catheter in me. And they brought a student nurse in, and they said, "Do you mind if he tries?" And I'm like, "Wait, try? You don't try, do you?" So it was always like, I get we're in the hospital in a serious situation, but we just made light of it, everything. And I said, "Well, wait." I said, "How many's he done?" 2. One was a female. And I'm like, "Okay, stop." And I said, "You got to come in with better percentages, okay? Like you've been 100% or something. Give me some better percentages other than 2." Anyway, everything worked out fine. So we had a lot of fun. And
So just, Paige, why do they put a catheter in some people? Like, what's the rationale for it?
So there's a lot of reasons. For most of the time, it's we want to just be able to really closely monitor what someone's fluid status is. So if you're dehydrated, you don't make as much urine, and if you have a catheter in, we know what you're making essentially minute to minute. So it allows us to make sure that someone is adequately resuscitated after they've been very sick and required a lot of IV fluids. Another reason could be that they may have had to have surgery close to the area of the bladder, and we're worried that it may have some trouble emptying and filling properly. And so just giving that assistance can be helpful. And then also sometimes people are just very sick and we're worried they're not going to be able to get up and use a urinal or go to the toilet. So it just makes it a little easier on them to not have to get up and move around.
For every surgery, do you need a catheter? Patients
No.
need a catheter? Okay.
No.
So just the more complex, longer cases, is that what you're thinking?
Yeah.
Yeah, okay. Good. So they know they can go home and,
yeah.
well, we have to say the good, the bad, and the ugly anyway.
That's right. That's right. That's what you asked me to do. But generally, it was a big surgery. Long time to recover for me. It was kind of shocking because I didn't realize till after what I really went through and what was going on. And I had no idea I was walking in the hospital coming out with 2.5 feet less of a bowel. I'm fine today. Everything's good. I've had a couple surgical repairs. I've had 3 surgeries since. I had the ostomy removed. That was a fun event. Because when they remove the ostomy, they pre-stitch you. But they don't give you any anesthetic when they start pulling the stitches. So yeah, that was fun. It was like lacing a football. But generally, my time getting in the operating room, here I am, I'm median. He's getting me all settled up and whatnot. It was a short visit with talk with him because 3 seconds enough talking and away you go. We had a good introduction and a good meet and greet. And, actually, I think I exposed you to I have sleep apnea as well. I got a good amount of issues. But I had this little tiny sleep machine. He goes, what's this? So he managed to hook it up. He rigged something up and hooked it all up for me too, which was great. So the experience was good. Like, you know, Dr. Sachs brought her team in. They came in within the hour. It was unreal. And everybody was there, boom, ready to go. And they just got the call. And they had to do this quick because, again, I was going downhill really fast. And the team was assembled really fast. This was a Sunday afternoon. So everybody was at home. It was a nice spring day, enjoying their family time. But lying on the table after 8 hours, I just felt so guilty after taking up all the time because we only had one surgery room at the time. We just didn't have another surgical tower. Now, another thing we figured out is that now we have 2 surgical towers. We did a little project and we made sure we have 2 full operating rooms. Because I felt pretty darn guilty hogging a room for 8 hours in case you needed to be in there. And so now we have 2 full operating rooms, and which is great. And our community needs that. Now, so the surgery itself was long, extensive, painful. I walked in for another surgical hernia repair that was scheduled, and the experiences were really, really good. It wasn't fun going through what I had to go through, but I'm fine. Everything's good. But I'm super thankful for the surgical team that we do have here, the excellent doctors we have here, and I can say firsthand, it's first class. So, and
So
the care.
Mike, you had to go to the city to have one of your surgeries. Was it the hernia repair? Or
Yeah, it had a.
Yeah.
It was pretty complex.
Probably
I had
they could
another-
afford the mesh and GBGH can't.
Yeah.
Right. Okay. And
So I went
what
down
was,
to-
what was your experience there? Now you walking into a hospital where nobody knew you, and what was it like?
Yeah, it was really different actually. Like, you're familiar with your local hospital, you know the people, you know the doctors. I was down at North York General, had a scheduled surgery. Everything went really well, but I got to tell you, like, everybody says, oh, it's better in the city, it's better here. I would say no. My experiences I had here, my 3 surgeries I had here, were equally or better.
So I have a question later on, which was how do you decide what you do at this hospital here versus over here? And the hernia one's probably a pretty good example. I mean, hernias used to be done everywhere, but now not so. Paige, do you want to just tell us about that just a little bit, why that would happen?
Yeah, so from the perspective of how to plan what your operating room program offers, you have to match it to what your community volumes and need is and what the expertise of the providers are that you've been able to recruit to your area. When it comes to something like a complex abdominal wall reconstruction for a post-operative hernia, I always tell patients when I meet them that, you know, you really want this to only have to be fixed once. So maybe you should see somebody who only does this. And when you get to the city, there's going to be people who are very focused on having sort of subspecialty training and doing sort of one thing that's a bit more complex all the time. And some procedures are better suited for that. But other procedures that are just very common and require the capability, whether you be from Northern Ontario or downtown Toronto, those are the ones that, in terms of recruitment and training, we're always trying to ensure that there's adequate access, particularly for those life-saving procedures. Not that they're necessarily easier or harder, it's just the volume may be higher, or the acuity may be that if somebody walks in with this, you can't transfer them down to Toronto. The person there in your hospital has to be able to look after you, and so that's one of the things that we take into account as well.
Thanks. Mike,
That's
any
not-
closing comments about your experience?
Yeah, actually, and on that note, I didn't have time to go to Barrie. I didn't have time to go anywhere else. You know, I was sliding down fast. So I was very thankful for the quality surgeries that we have here in our OR department that we do have here in doing that. So I'm very thankful for our hospital and what we have. We have a really good hospital here. And in Simcoe County, like I know I've got family in Aurelia and they've taken care of some family in there, but our hospital here is pretty precious and we have top quality care. So it's pretty important to me. And
Ian, you wanted to make a comment?
Well, I was just going to say, we are, though, a center of excellence for hernia repairs, just not big post-operative hernia.
Yeah, there's
So don't
different
feel,
types.
If you've got an inguinal hernia, like, come on down. We'll be happy to fix it.
They're on sale.
Yeah, that's right.
Thank you.
In fact, well, can we say that? you don't really want to go to the city for a standard, easy, run-of-the-mill surgery like an inguinal hernia, because you're probably going to be operated on by the resident or the early year trainee sort of thing. So Paige is, I don't know, like 1,000 she's done them. Or a gallbladder, right? Gallbladder's another great example, right?
Okay, you're hearing the deliberation of what makes people decide to go where for which, and which hospitals do what too. And it's not straightforward, but I think what you said, Paige, is there's some procedures every hospital has to be able to do: appendectomies, colostomies, colon resections. Otherwise, why do you have surgery, right?
It's
Okay,
the emergency
Karen.
and the routine.
Karen, your turn. Okay, talk to us about pre-op, peri-op, post-op. Floor is yours.
Yeah, thank you. So I wanted to talk a little bit today about more routine surgery. More, you've had your surgery booked by your surgeon, what happens next, and what's your journey at the hospital like. Not in an emergency fashion. So after you've had your surgery booked with your surgeon, the hospital will call you a couple of weeks before your surgery to do a pre-op appointment with one of our registered nurses. They'll just talk to you on the phone about your health history and go over your medications, make sure that you're fit for surgery, and if you need any further consultation, perhaps by our anesthesia department. And they'll help to just prepare you, and that's a good chance for you to ask questions. And then we ask you to call back in the day before your surgery to give you your time of when to expect to show up, and depending on the type of procedure that you're going to have, we usually ask you to come in about an hour, 2 hours before your surgery. So the day that you arrive at the hospital, we ask that you don't forget to wash your hands and don your mask, and they'll direct you, after you register at the front lobby, they'll direct you down to the surgery waiting area.
Who wants to answer the question, how long do I have to stay without food?
I'll turn that over to
They're pointing at you,
It's
Ian.
his fault. All
Yeah,
his
it's an
fault.
interesting thing. There is evidence around, so NPO status, nil per os, don't eat anything. You know, there is evidence that you could probably go longer or shorter time frames before having your surgery, but unfortunately, it gets lost in translation an incredible amount of time, or an immense number of times. So we basically just say don't eat after you go to bed, nothing after midnight.
Make it simple so people follow the instructions.
Yeah.
Okay, thanks. Karen.
So the nurse will call you in once you're registered and ready. They'll get you to change into a gown and a pair of slippers and a robe. And they'll just go over your health history and do your blood pressure and your temperature and your heart rate. And again, just assess how you're doing, review your medications again with you. We ask a lot of the same questions over and over again around your name and date of birth, just to make sure that we have the right patient and are meeting the standards that we're required to meet. Not that we don't know who you are, it's just part of the process that we don't deviate from. And so after they do that, they'll make sure that there's time for your surgeon and your anesthetist to come in and have a chat with you before you go into the operating room. Nowadays, if you're mobile, you can walk right into the operating room. Usually we'll get you to use the bathroom. Catheters are not necessary for every procedure. And they'll get you set up in the operating room, and there's usually a nurse by your side. All that time taking good care of you, and you always can ask questions along the way. And before you go to sleep...
Did I hear you say when you have to have that IV put in?
Oh, yes, absolutely.
And can I avoid that, or what?
No, you can't avoid
Okay.
that.
I can avoid the catheter, but I can't avoid the
the
IV.
nurse
Okay.
will not be received well by anesthesia
Okay.
when you're taken into the operating room.
Is it painful to have an IV put in?
It's a pinch.
Pinch. Okay.
Depends on how easy it is.
It doesn't hurt.
Okay, carry on.
It's all relative. It is really important that we start an IV in the day surgery area as we're preparing you for surgery, for sure. They'll just give you some fluids. And then that's how, of course, anesthesia accesses what they need to be able to give you those great drugs to put you to sleep. And they're the star of the show from then on.
What?
For pain control. So right before you go to sleep, you'll hear your whole surgery team gather around, and they'll do the first phase of the surgical safety checklist, which is another really important safety check that the operating room team does with every case. And so you'll hear them going over confirming your name and date of birth and your procedure and what you're having done, what side, review any pertinent laboratory results or diagnostic results, and then off to sleep you'll go.
Was that hard to introduce, Paige? Did people have trouble all congregating together with a patient at the last moment? Got to get the surgeon, got to get the anesthesia's already almost there, but
So the surgical safety checklist mandate from Ministry of Health for Ontario was fully implemented when I was still in my training 10 years ago. The rollout of that, I remember being fairly easily accepted where I was training in Hamilton. I think everyone kind of felt like, yeah, we do this. It's just not written down on a piece of paper, and maybe not every surgeon or team member may do it the same way every time. Why don't we standardize it? So I think it wasn't a hard sell where I was training. I know other places the culture wasn't there, and it was an adjustment to get used to having, the surgeon in the room for the anesthetic induction prior to it starting to do this. And I think overall the evidence was there, and when you present surgeons and anesthetists who are, science backgrounds, that this is the evidence that it prevents a lot of complications. Just to do something as simple as have a brief conversation, lasts less than 2 minutes at the beginning of every case, people started to buy in. And I think the data speaks for itself.
okay.
They're
Thank you.
low-risk events, right? But the classic example is replacing the wrong knee, for instance, and you'd think it would never happen, and it really would never happen in a place where there's only one OR running, but then you get in a big spot and maybe someone's not communicating as well as they could, and it happens. Or the other example is at sick kids. You go out in a room like this, and there are this many little kids running around their parents, and you try and find the kid. You got to make sure it's the right kid, and otherwise you could have problems, right?
Yeah.
So.
Okay.
Yeah, the surgical safety checklist is so relevant and important that hospitals measure it. So it's something that we measure on a monthly basis. We're always at 100%. If we deviate from that, even a fraction, there's a review. We're reviewing it. We review it as a governance team in the operating room. It's on the hospital scorecard, and it's publicly reported. If you're going for surgery anywhere, it's something that people shop around now, right? And you can look at the safety results and infection results of hospitals. So those are really transparent, publicly reported metrics now, which is great. So while you're asleep, there'll be 2 more phases of the surgical safety checklist. So certainly these guys are the experts on that, but there's always a timeout during the procedure just to, again, make sure that everyone on the team is working cohesively, that no one's running into any issues, and that things are going as planned. And it's formal. It's a formal timeout just to do that check-in. And then after the surgery, they always do a debriefing, whether it's quick or just that final check that, do you have the pathology results, and is everything going okay? Is Ian's, like the anesthesia, what they're doing is on track, and Dr. Churchill, just a chance for every part of the team to make sure that things are going as is, and the nurse is always there to make sure like all the instruments are counted and that final check.
Ian and I were talking facetiously about what's changed in the last few years, and the safety checklist is a big change in the last 10, 15 years. And it's all about communication. It's all about getting all the people in the room, including the patient, all talking together. That never happened before.
Yeah, that's exactly what it is. It's putting assumptions aside and really giving people a chance to speak up.
Sorry, I keep interrupting you.
Yeah,
Sorry.
that's okay. So you'll wake up in the recovery room. You'll generally have a nurse very close by your side. You'll have your blood pressure cuff on your arm. They'll be monitoring, again, your heart rate and rhythm and taking your temperature and just slowly waking you up and getting you to rouse around and start to sit up. You'll slowly wake up. They'll be there checking your pain and making sure you're comfortable. It's pretty much one-on-one care in the recovery area, and so you get that really great experience with our staff there. They're very specialized, trained nurses in the recovery room and in the OR, and we have an excellent team at GBGH. So you'll either, depending on the day and how busy it is, whether we have 1 or 2 operating rooms running that day, you'll either wake up and have a few sips to drink and use the washroom and get changed and be discharged directly from that area, or you'll be moved over to the surgical daycare area. We invite your support person to come in. People are allowed in again, and it's really important often that you do have someone with you because you're still groggy, you're awake, but as you're being discharged, they're going over some really important information about what to do post-operatively, when to see your surgeon again, and it's sometimes hard to remember. So it is great to have someone there, and of course you need someone there to get a ride home with anyway, and so they'll do all that for you. They'll call your ride home and make sure that you're ready to go, and then we'll follow up with a handout instruction in case you have any questions when you get home. And then the really personalized touch of GBGH is they do a really great job with their post-op phone calls. So a day or 2 after your procedure, they will give you a call at home just to make sure that you're doing okay, again, give you a chance to ask any pertinent questions, make sure you had all your information clear, that you have your appointment with your surgeon or your family doctor set up, and that you got your medications refilled, all of those really important things.
So just quickly to all of you, if a patient gets home and they have a rash or they have a pain that they didn't have before and they're not sure about it, do they come back to the hospital? Do they call the operating room? Do they call the surgeon? They call you, Ian? Do you have a standard protocol, or do you have any protocol?
I think generally, they're able to critically give some guidance around whether, like if it's a dressing, if it's the tape sometimes is giving you a rash, or if it's more serious and reddened, they certainly would advise you to, if you can call your surgeon's office or your family doctor's office, or certainly come back into emergency. We can't, it's not always easy to assess someone over the phone, so often the advice would be to come back in and be seen just to be safe. But
Paige?
Yeah, exactly, Karen. And the nice thing about our, we recently updated the medical record at our hospital to be completely electronic. And so there's a discharge packet that's provided to every patient once they're discharged from the hospital. And in that discharge packet, important things to look for that would make you concerned that you're having a serious complication from your surgery would be included, as well as things that might be a milder problem, say redness, things like that, in and around your incision. And this is your surgeon's phone number. This is you call the office during business hours. If it's after hours, your options being walk-in clinic versus coming into the emergency department based on whether or not it's a potentially serious issue. And I have gotten feedback from my patients that they really do appreciate that phone call, because sometimes by day 2, something feels a little off, you're not really sure what to do. And then you get this phone call from a nurse who has spoken to so many people in the same situation as you and can give you that little bit of guidance. I know it's definitely prevented a couple of emergency department visits where the patient felt reassured that everything's okay. Touch base with your surgeon in the next 24, 48 hours if you think it's not getting better, and it's been a good help for them.
So Karen, I know you wanted to talk about nursing staffing and shortage challenges, and you're also in the middle of an accreditation process and where the surgical program fit that. Can I hold that till after we get through everybody? Is that okay with you?
absolutely.
Okay. Ian, the floor is yours.
Geez, there have been so many things that have come up that I think, oh, we should talk about that, we should talk about that. I wrote some of it down, but I'll try and stick to some semblance of a plan, I guess. The irony, though, is that in anesthesia, we're not often remembered because of what we give to you guys, and I'm sure many of you in the crowd here have had colonoscopies, for instance, and probably don't remember much of it. And despite us chatting with you before and after, it's a side effect of our job is that we fly under the radar, which actually is preferred.
So just talk to me about that a little bit at the end. So you're given all these wonderful drugs, and somebody comes up and tells me a whole bunch of details about my surgery, but I've still got all these wonderful drugs on board. How do you manage that?
Yeah, it's interesting. And after I get your credit card numbers and accounts, like generally I'll
Paige, it's your turn to take over.
I warned you, you can't let this guy off the hook.
So yeah, and it's a safety issue too, right? And that's probably, and interestingly, I was speaking to a friend of mine who had another hospital, had their shoulder done, and if anyone's had their shoulder done before, an arthroscopy, it actually is a very painful procedure. And the jurisdiction of pain management is an interesting one that becomes a bit hospital dependent, but and specialty dependent, but anesthesia over the certainly sort of past decade have become the pain management experts, and a lot of advancements, I guess, in terms of what we call regional anesthesia. So local anesthetic injections, et cetera, nerve blocks, sometimes indwelling catheters to infuse over a longer term. But this friend of mine actually, speaking of the post-op phone calls, so he went home after a nerve block over his shoulder, and he felt so fine that he went to the shopping mall and whatnot. But then at 2 o'clock in the morning, when the freezing wore off, he was in a world of pain. But actually, an anesthetist called him the next day. So it's an interesting, and they discussed and talked about how to get back on top of the pain control, et cetera, et cetera. So I think probably something we'll see in the future is the pain management paradigm sort of evolving, and hopefully we can kind of get a handle on that here too with, it depends also, we've only just started doing a lot of shoulder arthroscopy within this past year with a lot of visiting orthopedic surgeons. But I guess the first thing we'll have to do is make sure that the PCA pumps are connected.
I think they are now.
Yeah.
They don't happen.
But that's a classic story, or a classic example of the way anesthesia has evolved over the years, right? Problems occur not because of someone's fault, but because of system shortfalls or system holes that exist, right? They talk about the Swiss cheese model, right? There's a barrier, there are a whole bunch of different safeguards, but geez, you'll be surprised at how often something can get through, and then you find that, oh, this person's in pain because their patient-controlled analgesia button isn't hooked up, right? So that's sort of been a more targeted focus of anesthesia over the past few years. But what I was going to say, way back when, I forget what the comment was, but it made me think of the phrase, "There's no anesthetic like no anesthetic." And back in the day, there used to be basically no anesthetic. And I can remember reading, as a kid, the autobiography of Roald Dahl. So he's the British author who wrote Charlie and the Chocolate Factory, et cetera, et cetera. And when he was a little boy, the doctor showed up at his home and took all of his brothers and sisters, or whoever needed it, pinned them down on the kitchen table, and he took a sharp scalpel and ran it up the back of their throat to remove his tonsils and adenoids. Which is pretty impressive, because even now, today, a tonsillectomy is a very painful, and in my mind as an anesthesiologist, a dangerous procedure for that risk of bleeding and airway compromise, etc. It's much safer than it was in those times, but it's really changed a lot in 100 years. And actually, we've got Dr. Richard Thomas here, a colleague here, and I was actually in Keith's spot on Saturday night. We were commemorating his 42 years of service to this community. And as part of that, we got a chance, or I got a chance, actually, I was talking to some of our colleagues, Bob Archer, Rick Coots, who else was in the graduate? Rob Stubbins. These are all well-known family doctors in our communities. But 42 years ago, anesthetics were different back at that time too, right? We didn't have, if anyone's interested, right, we put that finger tester on there that goes beep. That's monitoring your pulse, so it's called the pulse oximeter, and that's monitoring the oxygen content of your blood. And it's probably, in my opinion, sort of the most important monitor because it's giving information about your breathing, your ventilation, oxygen exchange, and also your hemodynamics to an extent because it's telling us how fast your heart is beating and also whether it's regular or irregular. You get a blood pressure cuff, obviously another important aspect, but with an anesthetic machine, back then, people didn't even have, we called end-tidal CO2, so those, actually I think I had to do a YouTube video relatively recently of, I've never done, this is my first live YouTube video, but for the foundation we did one to try and get some help with funding to find end-tidal CO2 monitors, which are another layer of the safety paradigm that help ensure that someone is breathing at a regular rate and also at a deep enough rate, we'll say. So it's just interesting to know how things have changed over the years, and it's all sort of in an ultimate aim to improve the patient experience and make it safer.
Have your drugs changed?
Yeah, good question. I mean, so I have 10 or 12 years experience, and interestingly, I would say there's one new drug in anesthesia that we're really, maybe two actually bigger ones. One of those two that I'm thinking of, we don't have access to at GBGH. Yeah, right, not yet, and it's, whereas, geez, how many drugs have we seen show up just in, because, you know, the medicine in general, how many new diabetic drugs have we had in the past 10 years? Like 5 or 6 or 7 new injectables, all the new blood anticoagulant drugs. Like these are all the, there's definitely been more in general medicine than in anesthesia.
It's my observation that the drugs got shorter and shorter acting.
Yeah.
And there's a reason for that. That's not just because it was cheaper or it was, they didn't
Yeah.
want you to have the full dose. It's just that they can cut it off when they need to cut it off.
Yeah, but it's a bit of a, you know, propofol is a classic example, and it's just something that actually has come into the public awareness, right, because of Michael Jackson, and pretty much if you've had a colonoscopy in the past 5 to 10 years, you've probably received propofol, and it's a bit deceiving as well, though, because again, I can have a conversation with you after you've woken up from your colonoscopy, but you probably really don't remember it that much. I have a good friend who picked his wife up from a colonoscopy and went to go get the car. This wasn't here, this was St. Elsewhere, and he went, "Where the heck's my wife?" And he found her wandering off at the edge of the parking lot towards a large highway. So they're short acting, but they're not completely gone, if that's fair to say.
And we don't have a whole lot of time left, but do you want to spend some time talking about recruitment of anesthesiologists to rural communities?
Yeah, super important. We're always looking for people. I would say so there's a paradigm in Canada at least of, so there's FRCP anesthesiologists who did their 4 years of medical training after university, and then you do 5 additional years of anesthesia training. And then there's GP anesthesia, which is what my and our colleagues here have done. So that's the 4 years of medical school, 2 years of general practice family medicine training, and then an additional 1 year of intensive, just 12 months straight of anesthesia training. And it's equivalent to sort of the combination of the 2nd and 3rd year of the 5-year training. And it gets to what Paige sort of spoke about earlier about these specialized centers. The 3rd, 4th, and 5th year of anesthesia are spent learning cardiovascular anesthesia, neuroanesthesia, thoracic anesthesia. But those sort of core foundational things, getting a lot of experience with emergency and general surgery and certainly obstetrics, is the realm of GP anesthesia, which is a foundational important aspect of care provision, surgical care provision in, I don't know what the population distribution is, but it's basically anything sort of Orangeville north in Canada, right? Where we don't have enough fully fledged, full-time FRCP anesthesiologists. So we have GP anesthesiologists who manage the ideally lower risk, but really we generally have to deal with whatever comes through the door for the lion's share of emergency cases. And then there's a very difficult sort of risk adjudication as to whether someone should be at a bigger center with more support systems in place or not. So the recruitment gets difficult because you want someone who will come here, but also wants to also do something else like an emergency medicine or hospitalist medicine or family medicine. All things I was doing throughout the start of my career, which have all kind of like unfortunately gone away because we don't have enough anesthesiologists, so I have to do anesthesia all the time. Is that enough of a spiel?
Yeah, no, I just commenting on the shortage, and you're absolutely crucial. Unless Paige has an anesthesiologist attending, that case isn't going to go, right?
Yeah.
So, I mean, you're
Just same
a
with
key
the
member of the
nurses, too.
team, and I guess everybody here needs to know that nursing, surgical, and anesthesia are three, but you got to have all three to make it work. And so I don't know if you were recruiting people and I heard your spiel. I think it's great. I would like to come too, Ian. So good work. Do you have more things to say, Ian, or can I switch off?
Well, the other thing I wanted to say though is, speaking of Paige and I, and really though, the OR experience is a team experience, and it's a team achievement every time you're working together to get through and fix someone's gallbladder or hernia or perforated bowel, right? No one person. I mean, I guess there's an old paradigm where the surgeon is in charge, and I guess ultimately they do have to be ultimately responsible, but it's very much a team environment, and it's very important for the team to work together well. And I'm very proud to say that our team, we do have a good team here at GBGH, and like people get along well, and we've got very excellent nurses who are experienced and are able to show up in, even less than an hour. There's a lot of call though, so that gets hard on people. Anyway.
Paige, we're going to hand it over to you now. Ian, thank you very much. Paige, you've got some things you want to talk about, the perioperative process, quality, and one thing that nobody's touched on, wait times.
I'm just stealing my notebook back because, we are a team. And I'm the team member who always has her stuff ready. Just in case someone doesn't. And that is how our program works.
Amen.
And that is why I think we do a good job. But I digress. So yes, I'm Paige Churchill. I'm one of the local general surgeons here. I'm the chief of surgery at Georgia Bay General, as mentioned, and I'm also the medical quality lead. So I do a lot of work with the hospital on data reporting and quality of care reviews, different initiatives within the hospital to try and meet new, ever-changing guidelines in the healthcare world in terms of determining a high-quality, safe, and efficient program at the hospital. So that's my background. We've talked a lot about the sort of flow through the operating room program from Karen. We've talked a little bit about the physicians who are responsible for your anesthetic and essentially keeping you alive and keeping your physiology stable while something very not normal is happening to your body during an operation. I always emphasize the complexity and the importance of what the anesthesiologist does to allow me to do the technical work.
The invasion.
Yes.
You are the invasions.
Yeah, he keeps the conditions steady and then lets me be the technician, which is a great way to sort of describe our partnership, I think. But yes, it is a 100% team effort every time somebody comes into the operating room. And there's the core OR personnel team, and that's myself as the surgeon, the anesthesiologist, the circulating nurse and the scrub nurse are the two nurses in the OR who are assisting with the procedure. But it goes way beyond that. You know, we have to have equipment that is sterilized. We have to have trays that are organized based on the types of instruments that somebody would want to use in a particular operation. And so there's trained professionals from our medical device reprocessing department who make sure that that's all in order for us. We have an environmental aide or environmental team members who are in there between cases, cleaning, resetting, making sure everything is sort of a clean and stable environment. And then the actual facility itself, unfortunately, we talk all about trying to increase our surgical capacity in the province, but you can't just, you know, put a sign on the front of a building and say, we're going to start doing operations here. There's a whole system to how the room is designed, the specialized equipment in place, how even the air is brought into and circulated out of the room to minimize the risk of infections. So it is a very complicated space to allow to function well. So I just wanted to acknowledge that there's so many people beyond just the frontline clinical staff that you meet on any given day that makes it possible for you to have an operation. Karen talked about the preoperative preparations. So from my perspective as the surgeon, my main role in the preoperative preparation is to help with diagnostics and deciding whether or not this is a problem that could be corrected surgically. And if it could be corrected surgically, should it be corrected surgically? So what's the risk benefit there in terms of taking somebody to the operating room? And then once I've made that decision, I kind of send that off to the preoperative program just to make sure that, yes, your health is good enough and everything's gonna be safe for us to proceed. And that's when the anesthesiologist first gets to have their say in the medical management of the case. We talked a little bit about sterilization. So we do have a whole department in our hospital that's dedicated to taking all of our equipment and instruments and ensuring that they're safe for use. And that's all just been recently renovated at Georgian Bay General Hospital to meet our accreditation standards. So it is something that is monitored by governing bodies to make sure that your hospital is meeting a requirement, kind of like that little green food inspection sign that you're seeing in the front window. We have to do that for our operating room as well. And then in terms of the execution of the surgery, the surgeons that we have in our community hospital, our primary ones are general surgeons, and we are lucky enough to have an ophthalmologist here as well. But in larger centers, you're going to see a larger mix of subspecialists that do anything from cardiac surgery, neurosurgery, thoracic surgery, which is sort of the lungs and esophagus in the chest, and a whole plethora of other specialists. And then in our efforts to bring more care closer to home, we have some regional partnerships with other subspecialists who can do some of their more less extensive surgery, so things that require maybe less specialized equipment, and actually come to our hospital and offer those things locally so that people don't always have to travel in order to access those resources. Anything on that, Keith, or?
No, you made it sound so simple. But getting surgeons to move and work in two hospitals with different people isn't always the easiest thing to do, right? So hats off to you for initiating this.
Honestly, just getting the calendar right any given day, that's the hard part. Once you get to the right place, it's usually okay.
It also actually reminds me, I don't know whether we've said it yet, but, and I don't know whether people know or not, but typically there are 3 doctors in the room because there's typically, for most surgeries, a surgical assistant physician, which is another skilled, important team member that is necessary as well for us.
Yeah, and so the surgical assistant is usually in our community a family doctor, but as you go into bigger centers that have training programs for surgery, it's often a resident or what we call a fellow, so somebody who's finished their residency but doing some additional training as well, who will be assisting. Sometimes it's a medical student. In other areas, it'll be a specialized nurse, so an RN assistant, or a physician assistant, so it's another type of healthcare professional who's done specific training to be able to assist in the OR. So yeah, there could be a lot of people involved to get you through. In terms of the operating rooms in our province, all of them are required to meet certain standards of quality, and there's lots of different programming that's both developed on the individual hospital level as well as on a provincial level, national level, and even international level in terms of reporting statistics and maintaining audits of our practices. medicine has kind of glamorized the whole idea of how airline pilots and airlines have to have these very sort of stringent protocols for the purposes of safety. And we've sort of adopted that mentality, and that's sort of where the idea of the surgical safety checklist came into place. I think surgeons all think pilots are cool. Anyway, it's sort of the mentality that we're taking into every time we take someone to the operating room. We want to make sure that we all know what we're doing, that we've done everything we can to make sure that our equipment, our setup, our lights, our information, everything is perfectly in place to make sure everything goes smoothly. And then the other thing is ongoing training and education. Unfortunately, medicine keeps changing, and we keep finding new things. And so what was up to date last year isn't up to date this year in terms of different types of approaches or technology, or even guidelines on how to manage certain medical issues. It changes year to year, so ensuring that both the physicians as well as the nursing staff are constantly engaging in training and updating their skills so that we can continue to offer what's recommended.
H, talk to us about waiting times. So there's been a lot in the news about people waiting a year for their cataract or a year for their hip surgery, and back surgery waits even longer sometimes. I guess the one thing out of tonight, you should get the message that Mike waited an hour. So when somebody really needs surgery, there is no waiting time. That's it. But for many others, there is. So tell us a bit about it and how you deal with it, because it's probably not the ideal situation it is right now in some areas.
Yeah, it is definitely the biggest challenge that the healthcare system in our province is facing when it comes to surgical care, is how do we get timely access for everyone to the maybe the not emergency procedures that they need, but we call them elective. So it's being booked and scheduled on a basis that if it were not to happen in the next 6 months, it's not going to kill you. It might be uncomfortable waiting for that, but that's just out of the province's priority system delineates things.
So how do you, at your hospital or the other hospitals around, because you're in touch with your colleagues, kind of have some uniformity to waiting?
Wouldn't it be lovely if it was uniform? Unfortunately, the way that our hospital system developed over the last few decades, everything was kind of siloed. You had each individual hospital and program was its own entity, and they didn't work together and they didn't talk together. And so some areas of the province were finding that their wait lists were growing and others were doing fine, and there wasn't sort of this group approach to solving the problem. The pandemic just made it everybody's problem. It finally became very clear that, everybody is behind. Patients are the ones who are suffering. And we need a uniform approach to trying to deal with the backlog. But unfortunately, there's also a lot of differences between a backlog in a hospital program that only has 2 operating rooms versus a hospital program that has 20 operating rooms. And so the tools in place to be able to deal with those backlogs needed to be kind of tweaked. So the province, under the Ontario Health organization, created some working groups to help pinpoint where the holdups were. Was it staffing? Was it equipment? Was it efficiency? And how can we try and get through people quicker? And then the onus was put on sort of the more far-flung, smaller communities to essentially band together and start having discussions on how to collaborate to move people through. And so funding was announced over in 2021 and 2022 to specifically target efficiency projects called the Surgical Innovation Fund. It was a total of $115 million that the province put up, but it costs about $2,200 an hour to run an operating room. And so $115 million sounds like a lot of money, but that might be only a fraction of the operating room budget in the university health network. And that's just Toronto. So it's a big issue. They're starting to look at moving any operations that maybe don't require a full operating room out of hospitals and into independent health facilities, or
I do have a question of that at the end, so
yeah,
we'll get back to that.
and as an option, and there's pros and cons to that. I have my feelings, and we can maybe discuss that further later. Yeah, trying to get creative on how hospitals can ease that burden on their own wait lists by redistributing the work.
So tell me what you do practically as a chief of surgery. Let's take a fairly common procedure, a biopsy. Doesn't need to be done tomorrow, but doesn't need to wait 6 weeks, generally doesn't need to wait. So how do you have a quality indicator so you can know that those women in the community that do need that breast are actually getting them within the correct amount of time, or you either put more OR time on or find another hospital to do them? Because that is your job, right?
Now, Karen will know a little bit about this too, because she's always honest about this. So we do have a wait time information system in the province. So when a patient gets booked for surgery, as part of the data audit of that, we have to enter when that patient was referred by their family doctor, when they were seen by the surgeon for the problem, when the decision was made to book the surgery. It may not be the same day as when they meet the surgeon. There may be more work to do first, but the day that they decide to book a surgery, and then the actual operation date. And that's all audited to make sure that you meet the wait times based on the priority level of that particular surgery. And so that's indicated by both the diagnosis and sort of the severity of the condition. So it's all documented and audited and then reported back on, I think quarterly, is it, Karen? Quarterly.
So there's documentation, and my impression is the ministry actually gives you more money or less money if you don't kind of meet some of those guidelines and expectations too, right?
Yeah, I don't think it's been tied to funding recently, just because everything got blown up by the pandemic.
Okay.
And a lot of hospitals are really struggling. We've been relatively lucky at our hospital in that we've been able to maintain our nursing staffing contingent to be able to run at, I think we've been up to about 140 to 160% of our pre-pandemic capacity in our OR in our efforts to ease the backlog. And that isn't necessarily for Midland patients for the most part. Like it's actually to help some of our regional stuff. So like I've mentioned, those surgeons coming from Barrie, Aurelia, Collingwood to operate on their patients at our hospital because we have the OR available has been sort of how we've worked on collaborating.
Yeah, system approach, and so their waiting lists are going down because you're helping out. Right? Ian?
I was going to say kudos to our new CEO, Matt Lawson, who previously was the chief financial officer and also came from RVH, and as part of that surgical innovation fund. I mean, I've sat through meetings for 10 years. We always had this list of a lot of OR equipment that we needed, and then this came along and Matt just knew how to make it happen, and suddenly, like, basically we got almost that entire list in the past, I don't know, 2 years, yeah. So Paige and he and other members of the team worked on that, and that's been a huge benefit to our hospital and community.
Knowing the funding system.
All right.
It's important.
Yeah.
It starts to become a game.
I'm going to take a break here and thank our sponsors and tell you about the next program, and then we'll come back to some questions to our audience, or to our speakers. Well, the audience doesn't have to answer the questions. So we have 7 wonderful sponsors that not only give us money so that everybody here can come free of charge, but also give us feedback on our programs and suggestions on what we do with future programs. So those 7 sponsors are Audio Hearing Aid Center, Georgian Bay General Hospital, the Center for Psychology and Emotional Regulation, which is headed by Anita Federici, the Hillcrest Village Care Center, a long-term care home managed by the Inns family, the Waypoint Center for Mental Health Care, Mink Insurance, led by David Mink, now known as McDougall Insurance, and Lois Lipton from Georgian North Real Estate Limited, providing commercial real estate and developmental services in Simcoe County. Can we give these 7 sponsors a big count? Okay, a little bit about our next program. It's 5 weeks and 1 day from tonight, so that's June 22nd. And we're going to talk about volunteering and its importance for both individuals and our community's health. The program is called Healthy Communities Need Volunteers. I think lately we've had health in every title that we've done almost, right? So a couple of questions that you're going to hear answered. Are there personal benefits associated with volunteering? Why are volunteers vital to the success of nonprofit organizations? We have 2 professional speakers with a wealth of information, and we have 3 people who have a huge amount of experience with volunteering throughout their entire lives with multiple organizations and a real passion for doing things for other people. So I look forward to that event. It's going to be a very special occasion to celebrate not only the wonderful work of our volunteers, but it's also a milestone for the Our Health program. Stay tuned for some more information. The promotional information for the Our Health series will be out on Tuesday after the long weekend, and you'll see what's in store for the next event and what we're going to be doing. So look forward to seeing you then. Questions? Karen, you didn't get a chance to talk about accreditation, and we talked about standards, but I don't think we talked about just how important accreditation standing is. Do you want to just give us a brief highlight of it?
Yeah, so this year at Georgian Bay in November, we're going to be going through our accreditation process. It's a really busy but exciting time. We go through it. It's a voluntary basis to go through accreditation about every 3 to 4 years, and it really just gives us a chance to update best practices and make sure that we're meeting the standards of care. In the perioperative department alone, there's 258 standards of care that we have to meet. And Paige talked about the sterilization department. I think there's another 198 there, and so on throughout literally every department of the hospital, right up through the board of directors.
And what you do for your accreditation this year here is what other hospitals are doing exactly the same. Is that right? It doesn't
Yes.
vary depending on the hospital or who you know.
Yeah,
Okay.
that's right. And so it gives us that chance to reflect on what we're doing, and that we're updating. Ian mentioned that is that always staying current with your practices. And one thing that I did want to highlight from that with our patient is what's really become gold standard is to involve our patients and families in the care that we deliver. And so we do have patient and family advisory committees in the hospital as a whole, and embedded on all of our operations committees. So on our surgical, on our OR committee, we have a patient and family advisor that, there's nothing like the patient's voice to really resonate with everyone and remind us why we're there and what we're doing. And they give great feedback on their experience and handouts and educational information from a perspective that we sometimes just overlook and don't see. And so we're really excited about the accreditation there. And speaking of,
they give you a score, and if you fail, it's not a good.
No,
not
I
a
was
good
just
scenario.
going to. Speaking of Matt Lawson, there is no score other than exemplary status that
Okay.
we'll be achieving, and I have no doubt we're really. It's just something that we're doing ongoing all the time, and it's really just a chance for us to show off in November the good work that we do.
Okay. One question, Ian, for you. One thing I've heard is people don't take pain pills, or they don't take the pain medication off because they're afraid they might get addicted. How much of a problem is that? Do people get addicted from the drugs that you give them? No, I just need. They don't. It's not necessarily you giving them. They just don't want to get started.
Yeah, it's an interesting. There's that acute thing, and really the anesthesiologist creating that is probably no. There is the history that's gone on in front of our faces over the past decade, and is kind of abating, but now is turning into a different sort of beast. And I'm interested to see what will be the case with cannabis in 10 years. But anyway, the prescription narcotics definitely did create almost a generation of challenges with pain, pain management. We'll just, I guess, leave it with that. The answer to the question is no, if you're treating your pain. But at the same time, we should always keep in mind that there are some agents that are better than other agents. And, as Mike was sort of speaking to too, pain isn't necessarily something to be avoided at all cost. Is that enough of an answer?
No,
Jump in.
Paige, because I know you write the prescriptions for the post-op goodies too, so.
Yeah, so I agree with Ian that in terms of the analgesics and the pain management during the surgery process is very unlikely to result in an issue with an addiction. However, responsibly prescribing post-operatively is important. And part of the Ontario Surgical Quality Improvement Network's mandate over the last few years was helping enrolled hospitals in this provincial quality program to adopt a standardized post-operative pain prescription for different types of surgery. So they always want you to prescribe as little as possible to meet the patient's needs and combine any kind of opioid analgesic with other types of pain relief, so Tylenol, Advil, so that you can get a synergistic effect and minimize the amount required. Because the less you take, the less likely you are to run into a long-term problem with using an opioid. So I would say that in general, short, low-dose prescriptions are safe. However, nothing is 100%. So it's always best that if you're not in a lot of pain and you are able to manage without it, certainly don't take it. Because not everyone will need to have a strong pain medication after surgery. And I'll advise my patients that start with your Tylenol, start with your Advil, and then if you're still having trouble, like you can't sleep because you're in too much pain, then that's when you would want to escalate to the next thing. And then if you don't require your full prescription, dispose of it properly, just so that it doesn't end up in somebody's hands who would be more susceptible to a problem.
Okay, as needed. Okay, thank you. Obstetrical activity. Is there obstetrical activity in an operating room?
Yes.
I don't remember it downtown. Well, they had their own suite of operating rooms in the obstetrical area, but in rural Ontario, what's it like?
Yes.
We should talk about the tripod of rural practice, although this isn't even really rural, but it's an obstetrical program, it's a surgical program, and it's an emergency department, and those all act together, and they're all necessary components of a community, a hospital that supports a community.
Yeah, very few hospitals outside of major centers will have a separate operating suite specifically for their cesarean sections. But some places in downtown Toronto, I used to provide C-sections as part of my practice before we recruited an obstetrician here locally. And I did my training in downtown Toronto at Mount Sinai, where they had 5 operating rooms just dedicated to cesarean sections. And our program here has 2 operating rooms dedicated to everything. So if that kind of tells you the volume that they're seeing there. But for us, they maybe are doing close to 8,000, 10,000 deliveries a year at that hospital versus our hospital, which is kind of around the 200 to 300 range right now, which is good, excellent for our community size. But yeah, emergency C-sections and planned elective C-sections are performed in our operating room on a regular basis.
Okay. And the nurses love it, right? They love to hear those babies crying.
I do have to say one thing about cesarean sections. My cesarean section patients coming in electively to have their baby, and my patients coming in for their stoma reversals are the 2 happiest patients I ever get to deal with, because they are going to walk out of that place feeling so much better than when they arrive, because we're just excited to have a baby, excited to not have a colostomy anymore.
Fair.
Probably equivalent amount of elation in those patients.
I'll agree with that comment.
How do you decide whether somebody needs a daycare, in other words, can go home at night, versus somebody has to stay in the hospital for 2 or 3 days or whatever time? How do you make that decision?
That's a team decision.
Sometimes it's my fault. Gave them too much.
No, seriously, how do you, so standard breast biopsy, it's done as an outpatient, well, certainly a bowel resection would almost always be as an inpatient. I think I'm pretty safe with that one, am I?
Yeah, but it's getting
But
shorter
people
and
are
shorter.
pushing the boundaries here.
Yeah, it's getting
So-
shorter and shorter. A lot of surgeries are being moved to day surgeries. Hip and knee replacements are starting to do same day, which used to require admission. And those patients were requiring admission mostly for their pain control. And so like Ian was alluding to, there's been a bit of a paradigm shift in how can we better control pain after surgery so that people don't have to be in hospital with a pain pump and could actually be at home with, say, a catheter that sits right in the joint, administering local anesthetic at a slow level, something like that, to be able to allow them to get out of the hospital and also free up capacity that we so desperately need. So it is a balance. Procedures that are considered low risk for complication, that are relatively short and are unlikely to sort of disrupt somebody's entire body system to a major degree, would be reasonable for people to be sent home. And then also just your past medical history. If you have had a heart attack in the past, if you've had breathing problems, that should probably be monitored overnight just to make sure that you haven't suffered a complication, then those would be patients that we'd be more inclined to at least keep for observation. And obviously bigger surgeries that kind of lay you up, or emergency surgeries where you're quite unwell and may need IV antibiotics or unable to eat and drink for a few days, those are the people who will need to stay in hospital.
Okay, but for most scheduled, you can tell people how long they need to stay. You can probably predict it. I wanted to talk about the surgical tower at some point, and this may be the right place to talk about the surgical tower, because that enables you to do surgery very differently than you did 20 years ago, right? So tell us about it. Mike, you know all about it too. You can talk about it.
Yeah, go for it. Do you want to talk about it?
Me?
or-
Well, I don't, actually, I came aware that we only had one operating room because we only had one surgical tower.
What is a surgical tower?
The surgical tower, Ian, I know Ian came up to me
Well,
and
I'm
said.
glad you don't remember.
Well, it helps monitor and visualize a lot of things that go on in the surgery.
Yeah, so there's been a shift in the last 30 to 40 years of doing more procedures, what we call minimally invasive, or using keyhole or small incisions and inserting a camera to show us what's going on the inside. And the reason for that is smaller incisions are less painful. And in general, they're less disruptive to sort of your internal organ systems to make those smaller incisions, so people can usually go home from hospital in a shorter interval. And so this tower, what it does is it coordinates specialized equipment for the camera, for insufflating gas into the abdomen or into a different part of the body to be able to give visualization and exposure, and then also have a big monitor to be able to see what's going on in high definition. And so
So is it difficult to look at a monitor instead of the patient's belly down here? Because that's essentially what you're doing, right?
have you ever played a video game?
I guess not.
all it
Okay.
is.
Okay.
Actually, Ian's comment after we got the new surgical tower in, he goes, "It's so much better in 4K." I think he was on
but
an
it
old
is-
black and white monitor.
It's
but-
It is very important that it's a very high quality image, because it has to be, very true to what is happening on the inside of the patient, so that the surgeon can, make those millimeter decisions in terms of how they're making progress through the operation to do it safely and be able to recognize any potential anomalies or problems that could be coming their way. And having new state-of-the-art equipment it just makes a huge difference in terms of the efficiency of the case and the safety of the case, and what we're willing to attempt in our site in terms of offering laparoscopic bowel resections, laparoscopic hernia repairs, and then even some of the arthroscopic surgeries for our orthopedic surgeons. We have gynecologists who come and do laparoscopic hysterectomies at our hospital. It's really opened a lot of doors in terms of what we can offer locally, because patients don't have to stay in the hospital a lot of the time after they've had the surgery. They're able to go home the same day.
So key piece of equipment. But
Very key, yeah.
If you look at one of the things that I think has been the fundamental change, we go back to the initiation of laparoscopic cholecystectomies, which was early 80s, maybe, something like that, Paige?
Mid-80s, I think.
So prior to that, everybody stayed in the hospital for 3 days after gallbladder operations, and gallbladder operations are very common. And now, out the same day and feel better, back to work. How long do they get back to work now?
I tell people if you don't need pain medication anymore, you can do whatever you want.
Yeah, okay.
Yeah, so if you're not sore, you can go and do
Yeah.
what you normally would
Yeah.
do,
So,
right,
change-
Richard?
big change.
I would say I've sat through, I mean, close to 1,000 gallbladder surgeries, and now, like, maybe I can count on two hands the number of open gallbladders I've seen in the past decade. So that's how much of a change there's been in that time frame now. It's pretty impressive.
So somebody talked about other sites of doing surgery, the potential to do surgery in private centers or centers outside of the mainstream hospital that we think of. So this is hot topic in the news. It's supposedly designed to reduce the wait list for some of the key surgeries. So I think they're going to introduce it in 3 stages. First of all, for cataracts, and then they're going to do for endoscopy and x-ray equipment, and then eventually hip and knee surgery at the 3rd year. What do the 4 of you think of this? Mike, would you go to one of these private clinics that they're talking about based on what you've read? Karen, would your staff work there? Ian, would you work there? Or how would you feel about it? Would you send patients there? Paige, what do you think? Like, just give us we've got a few minutes left before we have to quit. Let's wrap it up with this one.
Can't
Who
give me
wants
this-
to start?
Well, I could really make a quick comment. I know everybody's familiar with the Shouldice Clinic, and they're very well known for hernias, and that's their business. But other hospitals do this as well, depending on whatever the need is going to be. But these hospitals now are getting great equipment, great procedures, great doctors. So I have no problem going to our local hospital for any surgery, being a patient, because I've been there a few times and I'm very comfortable. And then, when they're going through all their little checklists and everything else along here, I'm just going through memory lane going, yep, that happened, that happened, that happened. And how professional and how well done it was done. Even chuckled when Karen said about the gowns. I know the slit goes at the back now. So but it's just how well organized, how structured that hospital is, and they've got excellent procedures on what they're doing. So I'm very comfortable with.
You're comfortable with the one, but
Yeah.
if
Yeah, but
you were
we'll see
going to
how
go
this-
to a private hospital, it would have to have all those things in place. I think, is that what you're saying?
But if you're going to have a place that's going to be able to allow people with a hip or knee surgery faster, I'm all for it too. As long as our hospital gets primary care and we get for emergencies and everything else, and they have the tools they can do, I'm all for a 2-tier health system.
So I think you've said one more thing. You don't want to see your current hospital jeopardized in any way for
Absolutely
what
not.
they're doing to start with.
Absolutely not.
Karen, thoughts on it?
I think it's hard to imagine the future, and it's hard to be resistant when we reflect back now and things have changed so much that we couldn't have imagined. So, I like to keep an open mind about where things are going to end up in a positive way, but I think the comments about maintaining the value of the community hospital is crucial and important, and we've had a lot of discussion about health human resources and how you need necessary care in a community hospital, and the triad between emergency care and surgical care and obstetrical care, and where are those providers going to be in a dual system is something that I think about.
Ian, what's your thoughts?
Yeah, I got a pamphlet in my mailbox the other day from, I guess it was Ontario Health Coalition. Sometimes they're a bit sensational, but I read the back and I was like, yeah, that's probably going to happen. Yeah, that'll happen. For me, it's the problem with the loss of health human resources, right? It's, anesthesia is the example, right? The daytime work is fine, but nobody wants to do the 24/7, 365 days on call. And if you give people that option, then they start to get siphoned away in your pool for getting people to help keep the doors of the hospital open. Just they're not going to be there. We're going to get into trouble, I think, with that, because we can't even do it now.
Mm-hmm. And Paige, you've been out and about to your colleagues. What's the word on the street, or what do you think?
Well, personally, I'm against for-profit health provision, just based on what I know. That doesn't necessarily mean that a non-hospital-based health facility couldn't provide care if it was publicly funded and nonprofit. So places working in tandem with hospitals to offload care that could be done in a less labor-intensive and less expensive setting to improve efficiency, I think is completely reasonable. But it needs to be very highly regulated. It has to be done in tandem with local hospitals to ensure that we aren't losing all of these very, high needs professionals to scenarios where they aren't, or where they're maybe offered more desirable work hours and potentially avoid some of the harder aspects of our jobs. A lot of people thrive on that and wouldn't be willing to give that up. A lot of people love doing the hard parts of our jobs, but if you have a lot of things pulling you in different directions, or if you're burnt out, it would be very attractive to go somewhere where you don't have to necessarily commit to evenings and weekends and overnights and emergencies. So I do think there's probably a role for it. We already do have a lot of independent health facilities doing procedures in the province right now, just not operating room level. It would be more cataracts and endoscopy, colonoscopy work right now. But the way that they're funded and the way that they're coordinated with existing hospital infrastructure has to be done very carefully, not to create an imbalance, in my opinion.
Okay, so I think I'm hearing the jury's out on this one. You're not sure. You're not sure. You're not saying no, but you're...
Well, I think there's a role. I just think it needs to be done properly and with a nonprofit
That
scheme.
would be a better option.
Yeah.
Okay. Okay. Thanks for all of you for being so straightforward on this. It's my time to say it's time to wrap up. So thank you to our audience for your attention throughout the evening, your clapping and your looks that I'm seeing, and to our TV and our online audience, thanks for being with us. Big thank you to our speakers. You all know each other, and I don't know you very well, so this has been a real opportunity for me to go back to an environment where I loved, and talking about the camaraderie and how it works together. I must say I missed that part of it in the latter part of my career, so thank you for sharing that with us. But Mike, particularly around being straightforward about what it was like to be a patient and what worked, what didn't, and how you coped. Karen, the accreditation and what's coming. Ian, straightforward about pain management, and Paige for all the other things that you've answered so eloquently. So thanks to the four of you. Thanks very much. We'll see you again in 5 weeks. That's 5 weeks and 1 day on June 22nd. Special occasion, and one we intend to celebrate. And stay tuned for the promotional information next week. Please take the opportunity to watch this program again. How do you watch it again? You can Google it on YouTube, Our Health Simcoe, or just any YouTube channel. You can get it there, and it'll be on. It'll be up later tonight, I expect. You can watch it on TV. There goes my beeper to tell me my time's up. So thanks to all of you for coming, and good night, and enjoy the rest of the evening. Thanks very much.
Call the Rogers TV viewer response line, email us, or connect with us on social media.
It was John's graduation. We were so proud. We all got together for a picnic. That's when we heard coming from the radio. So we stopped and we listened. It helped us get to safety. That's why when I think of John, because now he has a real future to look forward to.
Call Calling all journalism students, Omni Television is once again awarding scholarships to qualified students pursuing a career in third language journalism.
The Omni Scholarship has been really conducive to my development as a journalist, and it's shown me that, like having this financial support really opens up more avenues.
Omni is home to a variety of locally produced current affairs programs and daily national newscasts, broadcast in 6 languages. To learn more about Omni scholarships, visit omnitv.ca/scholarships.
You're watching Rogers TV Midland.